Dr. Anju. I'd call the next speaker, Dr. Dhileesh, who will be speaking to us on biologics in retinal diseases. Dr. Dhileesh is a consultant VR surgeon at Comtrust Hospital, Calicut.
Good morning, everyone. I'll be talking about biological drugs in retinal diseases. As we know, in the pre-biological era, that is before 2005, before the first biological drug, ranibizumab, got its FDA approval, we were talking in retinal diseases about the goal of treatment was rather the prevention of vision loss. And we were not talking about improvement in vision in chronic retinal diseases like diabetic retinopathy and wet AMD. But after the advent of these drugs, we started actually talking about preserving reading vision and improving vision in these patients. And the growth of the imaging technology in retina, like our OCT, and everything can be directly linked to this advent of these new drugs. Because before that, we had no reason to actually look at these OCT because we had nothing to offer them. And the financial aspect of this is that many of us became retina specialists actually due to these drugs. Everyone wants to do a short-term medical retina fellowship these days because there is actual money in it. And there has been a paradigm shift in management of all these diseases from neovascular AMD in that end of the life cycle to ROP, thanks to these drugs. The common pathway that most of these drugs addresses is the VEGF pathway. It is the final common pathway for most of these diseases. The hypoxia sets in initially, which causes release of VEGF from the RP and Muller cells, and these stimulate endothelial cell proliferation and vascular permeability through these pathways, as we can see. So coming to the basic structure, I'll not dwell too deep into this because ma'am has already, Dr. Sheena has covered this already, and these are the common anti-VEGF that we use. We'll try to see each of them separately. Coming to our innovator molecule, which is our ranibizumab. Initially, it has been designed like initially a mouse is immunized with recombinant human VEGF, and this will result in monoclonal antibody formation within the spleen cells of the mouse, and we isolate the B cells, and using a hybridomer technology, we amplify these monoclonal antibodies, and the mRNA coding for the CDR, the complementarity determinant region, is isolated, and then the DNA sequence is generated using RT-PCR, and then it is transferred to a phage vector, and finally this is synthesized using an E. coli. E. coli bacteria is what generates the final drug. So the final drug will have 95% human component and 5% murine component. So that makes it a humanized antibody. So it binds to VEGF-A, and because of its 95% human component, it has very low immunogenicity. And the molar dose in our intravitreal formulation will be 10.4 nanomoles, and the vitreous half-life is around 3 days. I will not cover the clinical aspects, we will just stick to the drug aspects and pharmacokinetic aspects of it. So there is very low systemic exposure of less than 0.01%. How is it different from the other drugs? In bevacizumab, the initial DNA sequence is generated through similar procedure from the mouse only, but later on the full antibody fragment is used in the case of bevacizumab. Both FC and Fab fragments are here, whereas in ranibizumab it's only the Fab fragment that is used. And another difference is that mammalian cell culture with Chinese hamster ovary cells is used in bevacizumab, whereas E. coli is used in ranibizumab. So being a larger molecule, it creates a it clears slower than ranibizumab from the vitreous. Effect is similar due to the difference in binding affinity in most of the conditions, but it is considered to be slightly superior in retinopathy of prematurity because of its longer half-life within the vitreous, and it has a slower systemic clearance, which also creates a little bit of systemic issues in ROP especially. Aflibercept is not a monoclonal antibody, it is a recombinant fusion protein, as Dr. Sheena said. So it actually has VEGF-R1 and VEGF-R2 receptors bound to the constant heavy chains. And VEGF-A, VEGF-B and PIGF actually bind to this molecule. They are trapped within it, and so hence the name VEGF trap. So it has the least immunogenicity among all the anti-VEGF because there is no murine component here. It is almost fully human. And the vitreous half-life is also longer at 7 days, and the molar dose is slightly higher than ranibizumab of 17.4 nanomoles. Because of these things, it supports longer dosing intervals. It is more binding affinity. Therefore, it is considered superior to ranibizumab in large PEDs, DMEs with poor vision, etc. And brolucizumab, as it is a smaller molecule, single chain variable fragment is the only thing present here. Only the variable light chain and heavy chain are linked with a peptide linker. And it's a very small molecule of 26 kilodalton. And as a result, it has a very high molar dose of 231 nanomoles. The half-life is not that long, but because of the higher molar dose, it stays in the eye much longer. And it also has greater tissue penetration due to a smaller molecule. Theoretically, it should have lower immunogenicity because there is no FC fragment, but practically what we see is that there is a higher incidence of intraocular inflammation of 2.2 to 4.4%. Why is it so? Because it causes anti-drug antibodies. There is even patients who are receiving it for the first time have been shown to have anti-drug antibodies because it is said to have cross-reactivity to unknown environmental antigens. So because of this, there is an increased risk of intraocular inflammation, even occlusive vasculitis and severe vision loss. Coming to the other pathway that these molecules address is the angiopoietin pathway. Normally, the angiopoietin 1 pathway binds the Tie2 receptor and causes vascular stabilization, whereas angiopoietin 2 binds to the same receptor and causes vascular destabilization. And chronic retinal diseases, it causes an increase in angiopoietin 2. So, faricimab is a drug which binds both VEGF as well as angiopoietin 2. And it is also synthesized from CHO, Chinese hamster ovary cells. It is a slightly larger molecule of 149 kilodaltons, but it has a higher intravitreal dose and a higher molar dose, and also a longer vitreous half-life of 7.5 days. So this will give it a longer action of dosing interval of up to 16 weeks. It also has reports of intraocular inflammation, slightly more than your ranibizumab and aflibercept, but slightly less than brolucizumab. And rare reports of occlusive vasculitis too. Anti-drug antibodies have been reported in them also. Biosimilars, actually Dr. Sheena already covered. So in this, the protein sequence is taken from the reference drug and the amino acid sequence is directly identified and it is reverse translated to generate the DNA sequence. And this is later cloned into mammalian vectors and to generate ranibizumab. Several biosimilars are already available in India for ranibizumab. Aflibercept biosimilars are on the way. Their adverse event profile and clinical efficacy are similar to the parent molecule. The some adverse event that's been recorded is mostly due to the logistic issues rather than the drug molecule itself, inflammations and all. Coming to gene therapy, Luxturna is the molecule that is already available, and this is gene therapy directed against biallelic RP65 mutation associated retinal dystrophy. It is used in Leber's congenital amaurosis and retinitis pigmentosa. It showed promising results of 43% of patients improved around 9.8 letters, and these gains persisted at 3 to 4 years. This is a one-time subretinal injection. And the cost as of now is prohibitively high. Bilateral treatment will cost around 7.2 crores in Indian money as of now. And the newer drugs that are coming up in this are tarcocimab tedromer or KSI301. This is an anti-VEGF antibody biopolymer conjugate. This biopolymerate binds the drug and extends the intraocular durability. Phase 2 trials have shown good efficacy with extended dosing interval up to 16 weeks. Phase 3 trials are ongoing now. Sozinibercept is another thing which can bind VEGF C and D. So these are not the primary molecules. So it can be used as an adjuvant along with VEGF-A inhibitors. Phase 3 trials, however, did not meet the primary endpoints. Further research is going on around this lines. And RGX-314 is a subretinal gene therapy. Actually, it causes sustained release of anti-VEGF within the eye. So this is another molecule which is also in trial. So this is a treatment for wet AMD, a gene therapy which releases anti-VEGF, which is also in phase 2 or 3 trials. And gene therapy for inherited retinal disorders is something that should be coming up in the next 5 to 10 years. It has been used to treat X-linked RP, which is associated with the RPGR gene. Botavec and Larozova are promising molecules in this regard. And choroideremia, there is the BBJ1, which is also in trials. ABCA4 associated Stargardt disease is another disease they are looking at, and these two molecules are showing promising early results. LCA and OPGX, these are LCA caused by mutations other than our genes that the Luxturna targets, the RP65. This is a gene therapy targeting this particular gene, GUCYD2. And this one is particularly interesting, the MCO010 by nanoscope pharmaceuticals. This is said to be gene agnostic. So RP, it's very difficult because the RP has more than 120 genes causing retinitis pigmentosa, but this is said to be gene agnostic. It codes for opsin gene, so it's said to improve regardless of the mutation that causes the RP, it's said to improve vision. As of now, the gains are minor. 3-line ETDRS gain sustained at 2.5 years has been shown, but this sounds very interesting. In conclusion, I have to say that biologicals have revolutionized treatment of retinal diseases, and newer molecules can lessen treatment burden for chronic retinal diseases. And gene therapy is another horizon, as they changed our paradigm of management in chronic retinal diseases about 20 years ago. Possible paradigm shift can come in inherited retinal disorders down the line. Thank you.
Thank you, Dhileesh, for that nice overview of what we are doing now and also